Hello and welcome to the University of Washington Cardiometabolic Echo Session 5. I'm Nicole Earhart, one of the adult endocrinologists here at the University of Washington, and we're really excited today to continue our series. So today we have Barbara Onumah, who's going to be talking about our insulin-sparing agents, our injectables for diabetes management. Additionally, we have a great case discussion, and we have a series of great panelists to further enhance our learning. So we've got Kelly Branch, our adult cardiologist from the University of Washington, Nyan Arora, our nephrologist from the University of Washington, Laura Montour, our obesity and family medicine specialist, then of course myself and Barbara, both adult endocrinologists. So go ahead, Barbara, take it away.
We're going to focus today on GLP-1 receptors, and we'll focus on cardiovascular and renal benefits of this class of diabetes medication. I know that last echo session we talked about a similar drug class that follows similar pathway, that was the DPP-4. Today we're going to focus on GLP-1 receptor analogs. The objectives for today's session in the next several minutes will be understanding the mechanism of action of incretin-based treatment with GLP-1 receptor agonist drugs, and also understanding efficacy benefits on cardiovascular and renal system and potential adverse effects of various drugs belonging to the class. I'm certain that we've all probably seen a cartoon similar to this that depicts the progression of diabetes. We know that diabetes is a progressive illness, and it starts out even before the diagnosis is made. We do know that diabetes increases the risk of having both microvascular and macrovascular issues and complications. Usually it's associated with glycemic control, but also with the duration of the illness. And as time progresses with diabetes, the management of the disease has to progress along with it, even though people may have been continuing to do the same things they were doing before because the disease progresses. So we have to progress our management with it. It has to do with persistence, insulin resistance, and depletion of beta cells and decrease in insulin secretion. So oftentimes we are left with having to choose multiple agents as the disease progresses to be able to accomplish good glycemic control and to minimize and diminish the macrovascular and microvascular complications. Several scientific organizations exist that help us come up or formulate pharmacologic therapy for hyperglycemia in persons with type 2 diabetes. In the recent past, we have been fortunate, for those of us who practice and treat persons with diabetes, to have many more tools in the toolbox. Now we no longer just focus on using the therapies to just reduce glucose, which is usually one of the main components of treating diabetes, but we also like to focus on what other comorbidities may exist so that we can tailor therapies to actually reduce the risk that comes with those associated comorbidities. So on the left of your screen, we're going to be focusing on persons with increased risk of cardiovascular disease, or persons who have risk factors that increases their chances of having a coronary event, and we're focusing on GLP-1 receptor agonists. Of course, there are several factors that we have to consider, including patient preference, including cost, formulary issues. I'm sure we're going to be discussing some of that as we discuss the cases today. On to GLP-1, glucagon-like peptide 1 is an incretin, and there are two main peptides that belongs to the family of incretin hormones. Glucagon-like peptide 1, GLP-1 for short, is from L cells of the intestines and colon. Then there's another one that we haven't really spoken much about, but I'm sure we're going to be speaking a lot about this other incretin in the very near future, which is glucose-dependent insulinotropic peptide GIP. This particular incretin hormone is from the K cells in the small intestines. These incretin hormones usually have the ability to glucose-dependently augment insulin secretory response during periods of hyperglycemia. There is this phenomenon of incretin effect, which is the phenomenon whereby in healthy individuals, exposure to glucose through the GI tract elicits a higher insulin response than exposure to glucose through an intravenous source. This phenomenon actually is significantly diminished in persons with diabetes compared to healthy individuals. This is actually what GLP and GLP receptor analogs, which is the drug that we're going to be discussing, helps augment in persons who have diabetes, and that's what we're going to be discussing today. When we talk about GLP-1, we're talking about a hormone that has lots and lots of organ results that all leads to an endpoint that we actually like in managing persons with diabetes. It has effects in the brain to decrease food intake. It has effects in white adipose tissue to increase glucose uptake, and brown adipose tissue to increase thermogenesis, in the pancreas specifically to increase insulin secretion and decrease glucagon secretion, which is very important, and also in the stomach to reduce gastric emptying. It has other effects as well throughout the body, and all of these effects put together results in the effect of having decreased glucose and increased cardiovascular benefits down the line. I think some of these are still being sorted out as to the reasons why these drugs, even independent of their glucose lowering effect, also results or leads to cardiovascular risk reduction. This table is actually a little difficult to read, but I wanted to just put a summary of all the medications that are currently have been approved that belongs to this class since 2005. 2005 was the first time that we had first FDA approved medication belonging to this class. And this medication is exenatide, which is marketed as Byetta. It was actually exending 4, which is from the glia monster saliva, which when I was a fellow in 2005, that's when I was a first year fellow. This was the first GLP-1 that was available. And it was very revolutionary in terms of having an injectable that was not insulin, but it actually augmented the effect of insulin. Now, since then, exenatide has actually been reformulated, so to speak. This was a BID dosing medication, but was reformulated in 2012, and we had exenatide once weekly. And then even later on in 2018, the formulation was the same, but the device in which the medication was administered in was changed because of constitution issues with the prior device. And so we had a precise formulation, which is a little easier to use. Between 2005 and currently, there have been several GLP-1s that have actually been approved by the FDA for use for management of diabetes, and they're all listed here. There's a 2 times daily exenatide, which is still in use. There's once weekly exenatide, and then there's once daily liraglutide. Some of these formulations were not used as monotherapy in the United States, but used in combination. So there's lexazenatide, which is used in the United States as a combination medication. And then, of course, what even revolutionized this drugs even more was the once weekly preparations that made it even more easier to use and more convenient for patient populations. So we'll talk a little bit more in more detail about some of these medications and some of the studies that have proven them to be very good in terms of reducing A1Cs, but also improving cardiovascular risk. I have another cartoon here that is again showing all the devices that are currently available. They're all injectables and they're all in pens. Some of them are single-use pens, which makes it really easy for persons to use because there's no measuring of the medication. And this is from a recent publication in 2001 that showed that the dulaglutide pen was the favorite because of its ease of use. There are several other variations of different pens that exist. We see the dosing up top of exenatide twice per day. Then we have the once weekly medications and then the combination medications with insulin as well. In terms of efficacy for glucose lowering for these medications, They have all proven to be quite efficacious when it comes to lowering A1C, which is usually the primary goal of a majority of diabetes medications. So ranging from exenatide twice a day all the way on to semaglutide once weekly, and then most recently, the only oral GLP that's available, which is oral semaglutide, we see that there is significant hemoglobin A1C reduction in panel A across all of the GLPs. So comparing all of the GLPs, semaglutide seems to be the most potent in terms of A1C lowering, but all of them have quite a robust effect on lowering hemoglobin A1C, either when used in addition or a second-line therapy to metformin or other diabetes medications. And then the same for glucose, both fasting and postprandial. Then the other significant effect of these medications is the ability to cause significant weight loss, which for the most part, majority of our persons with diabetes type 2 would benefit from weight reduction because it improves their overall metabolic profile. We see that again in panel C, semaglutide weekly sub-Q injection tends to be the most robust, the most effective in terms of weight lowering in all the efficacy trials thus far, I should say. Most recently, there have been even higher doses of these medications approved. For example, dulaglutide for the longest was available in only up to 1.5 milligrams. So the starting dose for dulaglutide, which is started at 0.75 milligrams, and then could be advanced to 1.5. There have been studies showing that it was safe and efficacious and caused even more A1C lowering at higher doses and also more weight reduction. And so it's been approved for higher doses up to 4.5 milligrams. And the 4.5 milligram dose has been shown to reduce A1Cs by 2% and with significant weight loss of up to 10.4 pounds. The same for semaglutide. Semaglutide higher dose has recently been approved from 0.25 milligrams, which used to be the starting dose, 0.5 milligrams, then 1 milligram, now can be advanced to 2 milligrams. And this can cause an even more A1C reduction up to 2.1% with a significant weight loss of close to 14 pounds. So these are significantly potent medications that can actually result in significant A1C lowering that we previously would not see with any single agent except for insulin. Of course, with every medication, when we talk about the pros, we have to review some of the potential adverse effects. And for the GLPs, the most common adverse effects have been the GI side effects. Nausea, vomiting, diarrhea has been the most common side effect for all of them. Initially, there was concern about inflammation of the pancreas and even for some pancreatic cancer, but we have plenty of long-term data studies showing that there is no significant risk associated with these medications compared to placebo. There is a black box warning for persons who have medullary thyroid cancer or family history of medullary thyroid cancer, and we do not use these medications in those persons because C cells of the thyroid contain receptors for GLP-1, and it's not recommended to use them because of risk of hyperplasia in those C cells. So for persons who do have medullary thyroid cancer in themselves or their families, or MEN or any multiple endocrine neoplasia type, it's actually contraindicated to use these medications. For semaglutide sub-Q, there was a significantly increased risk of progression of retinopathy in persons who had moderate to severe retinopathy. And there's a question of whether or not it was from the drug or whether it was from the rapid decline in glucose and A1C. This was not looked at in oral semaglutide because persons with moderate to severe retinopathy were excluded from those studies. So this has to really be considered carefully when considering initiating semaglutide in persons who have moderate to severe proliferative retinopathy, because that signal has come up. I have here a list of cardiovascular trials, and I'm not going to go through all of them, but I'm going to quickly highlight the important ones, or the ones that have really led the discussion for cardiovascular benefit for these types of medications. First, and I believe the most important one that really brought this class of drugs to the forefront is the LEADER trial. The LEADER trial was looking at liraglutide, and it was a randomized placebo trial which was trying to prove non-inferiority compared to a placebo. And the primary endpoint for most of these trials were looking at major adverse cardiovascular events. The primary endpoint was composite of cardiovascular death, non-fatal MI, or non-fatal stroke. And there were several secondary endpoints as listed. What this trial found was that there were significantly lower rates of all-cause death and cardiovascular death with liraglutide. So not only was there a significant reduction in cardiovascular outcomes or cardiovascular risk, but also there was a significantly lower rates of all-cause death and cardiovascular death with liraglutide. And this was the first study that actually showed a drug actually reducing risk of dying from cardiovascular disease in terms of diabetes drugs. And so I think this set the stage for all of the other trials to start looking closely to see what other signals could be found with the GLPs. Here is another version of representing the data, and we can see here that all of the endpoints were in favor of liraglutide. Also important to note that these GLP studies were also looking at macroalbuminuria, and we found that there was a reduction in macroalbuminuria in these studies favoring liraglutide. So here the hazard ratio was 0.78 in favor of liraglutide compared to placebo, which is important for persons with diabetes and reducing renal disease and progression of renal disease. The next trial here that I'm just going to go over real quickly, it's another non-inferiority study. And here we're looking at persons who were exposed to either once weekly semaglutide versus placebo. Again, same primary outcome, major adverse cardiovascular event. Most of the results were in favor of the GLP drug. We see here that the retinopathy complications, the hazard ratio was higher for the drug compared to placebo. And this is the reason why persons with moderate to severe retinopathy, we may have to actually take pause when we are considering prescribing this particular GLP. It's also important to note that it was not statistically significant for cardiovascular death and death from any cause as compared to the prior study, which is the LEADER trial with liraglutide. REWIND trial looked at dulaglutide, and this study is often compared and contrasted with liraglutide because whilst liraglutide looked at persons with high risk, a high cardiovascular risk, persons who had already had a cardiovascular event, the REWIND trial actually had a higher percentage of persons that did not already have an event. So it was more of looking at a primary prevention type. And the persons in this group had a higher percentage that were primary prevention, more of persons that you probably see in your usual practice, where you were trying to actually get them to prevent them from having a primary event. This was also set up to be a superiority study as opposed to a non-inferiority study. The study was also one of the longest. Patients were followed for 5.4 years. And dulaglutide was noted to be superior to placebo in improving glycemic control and in decreasing cardiovascular events, particularly stroke in persons with diabetes and higher cardiovascular risk. This was a very important study because it actually showed that these medications not only decreased risk in people who already had an event, but could also prevent persons who had not had an event and were considered to have risk factors. I just have one slide on oral semaglutide because this is the only oral agent we have in this class. And the studies for this have shown that, again, There is some benefit, particularly from death from cardiovascular causes. We see the hazard ratios are listed here, and the most significant hazard ratio is hazard ratio from death from cardiovascular causes. We see that this drug, which is oral semaglutide, which in fact is the first oral peptide available, also has some significant reduction in primary outcome of MACE. Overall, we know that the GLP-1s, when you look at persons with history of cardiovascular disease, tend to have a benefit for reducing cardiovascular risk. And even persons without cardiovascular disease, there's still a signal and a trend that these medications decrease the risk of them progressing to have cardiovascular events, particularly the Rewind trial, which looked at dulaglutide. Then when we look at the renal endpoints, not all the studies that are available look specifically for the renal benefits, but some of the studies did look at renal benefits, particularly for nephropathy and macroalbuminuria. And for the most part, there was a trend that was favoring the renal endpoints, and specifically the LEADER trial, which looked at liraglutide, as well as the Rewind trial, which looked at dulaglutide. Those two trials, as well as SUSTAIN, did show that there was benefit in the renal standpoint in terms of lowering microalbuminuria. This, again, is very helpful for persons with diabetes. We had fewer nephropathy events for LEADER trial, and we had fewer new or worsening nephropathy for semaglutide, and the same for dulaglutide. The other studies did not actually have significant numbers to actually show a reduction in the percentage of albuminuria because they were not powered to do so. For the last few slides, I'm going to talk about a new dual GLP, which has just recently been approved, and this is tirzepatide. I'm not sure if it's available on the market or if anyone on this ECHO panel has used this. I have not used it yet. It was approved, I believe, on May 13th by the FDA, but it's a dual glucose-dependent insulinotropic polypeptide, GIP, and a GLP-1 receptor. So this is two incretins together in one compound. And the studies that actually led to the approval of this medication showed a mean A1C reduction of up to 2.6%. This is even higher than the higher levels of the most potent GLPs by themselves. There was also a dose-dependent body weight loss between 8 and 14% from starting weight. This drug is quite potent and seems that when it's available and when used in the appropriate persons, is going to really help, for starters, because this is what it's only approved for, reduced A1Cs and improved glycemic control. There is currently no cardiovascular data for this drug. It is coming, and there is no weight loss data officially. The indication that it's been approved for right now is for glucose lowering and A1C reduction. It was superior to semaglutide in head-to-head comparisons in reducing A1C and body weight, and it did have similar GI adverse effects. So if you're going to get more bang for your buck, it sounds like this is the drug. It was also superior to insulin in reducing A1C and body weight with a lower risk of hypoglycemia, which is always one of the things that we worry about when we are titrating insulin doses. Looking at tirzepatide, 5 milligrams, 10 milligrams, 15 milligrams is going to be existing in 2.5 milligram increments. So it's going to start from 2.5, 5, 7.5, 10, 12.5, and 15. All these graphs and studies are from the seminal New England Journal paper that really talks about the detailed studies and how this medication was associated with significant A1C lowering, significant change in body weight, also some improvement in lipid profile, and no higher adverse effects in terms of GI adverse effects and hypoglycemia. It is going to be marketed as Mounjaro. It was approved on May 13th, 2022, and we should stay tuned to see what happens with this. It would be delivered in the same one single-use throwaway device as the dulaglutide pen. So hopefully not a lot of learning curve for persons who have been exposed to this because the same device has already been on the market for a while. A few take-home points. GLP-1 receptor analog is generally effective and well tolerated. It reduces the risk of major adverse cardiovascular events in persons with diabetes, with the highest effects in persons with known risk of cardiovascular disease compared with those without. And it's associated with reducing the risk of kidney disease by causing a reduction in macroalbuminuria. The cardiorenal benefits may be mediated by several effects on A1C, blood pressure, and other cardiovascular risk factors. The most common side effect is GI symptoms. And then, of course, there's this new GIP, GLP-1 receptor agonist, which shows even more A1C lowering and weight loss improvement and metabolic profile. We have to wait to get those additional studies before we can speak to that. We know for a fact that it actually has more A1C lowering compared to some of our most potent GLP monotherapy. That's it.
Thank you. That was a great discussion. One thing that came up in the chat was with the nausea side effect profile, any pearls for mitigating that nausea or keeping people on it so that they can get used to the medication?
Some of the recommendations, in fact, in the package insert has been titration. Titrating the medications and starting on a lower dose usually can mitigate some of that. Also, some of the package inserts in specific GLPs would give recommendations as eating smaller meals, avoiding eating till you're full. So just eating until you're just not quite full, because if you eat till you're too full, you might actually get some of those nausea symptoms. There have been some talk about short-acting and long-acting GLPs and whether or not some of those actually have more effect on nausea versus not. There was one study that I looked at whilst preparing for this that said that it didn't really matter because in some persons it mattered and some persons it didn't matter. The short acting was supposed to cause more nausea because the long acting you developed tachyphylaxis to it eventually. And there was another study that said that it really didn't matter. So it's basically doing the slow titration of the medications and doing things like not eating till you're too full. Sometimes for some strange reason, changing from one GLP to the other, one person might be really intolerant to one GLP, but then changing it from one GLP to another, they may be able to tolerate.
Great answer. I also ask about a history of reflux or GERD, and I will start a PPI empirically for that first 6 to 8 weeks of therapy. Even if they're not having symptoms, it tends to help with the titration plan, and then use it as a positive goal to go out and walk, because obviously your gut moves with peristalsis from activity and exercise. I just tell people, listen to your body. It may be telling you the foods that you can and cannot eat, and it may be a negative reinforcement for those bad food choices as well, so that you can learn from your body as well. My last question, how will you start using GIP, GLP-1 combinations outside of GLP-1s when they are commercially available, which will be soon? I've been thinking about that a little bit myself.
I actually have persons who are on maximum doses of GLPs, like 4.5 of dulaglutide, and they have also taken U500. So I believe in those persons, it would be a great medication to add on instead of continuing to titrate insulin doses up, because they're doing all those things that we would recommend them doing in terms of lifestyle modification. They're on all the other non-insulin agent, and they're still on quite a bit of insulin, with the hopes that with that medicine, they may be able to actually not need more insulin, or we may be able to reduce their insulin dose. So that's one group of persons that I could potentially use that medicine in.
Exactly. That's what I was thinking about now that we have the higher dose weekly GLP-1s. If we're not at the goal, our desire is also more significant weight loss, to consider them. what may limit them is the nausea profile, although what I've heard is that a lot of people are saying it's not any different than the straight GLP-1. Really quick, Laura, we haven't really talked about liraglutide or semaglutide for weight loss and the dosing for that, primarily because most of the time a lot of the insurance companies exclude it. But could you just mention where you've been successful using it, particularly as a weight loss medication at the higher doses, which would be, the trade name is Saxenda and Wegovy?
Yeah, most insurances don't cover. I'd say TRICARE, Boeing, patients that work for Microsoft may have the ability to get those covered. But most times when I'm prescribing them for weight loss, it's for if they have type 2 diabetes or if they have metabolic syndrome or prediabetes. But those ones also, you have to try metformin first.
Great points there. So Grant, you want to go ahead and start our case presentation?
Sure can. It's a 58-year-old female with history of type 2 diabetes who up until now had been very well controlled with glipizide and Bydureon. Then she lost a bunch of weight and was doing really well exercising and diet wise. Now she comes to me as a new patient and during the rooming process gets the A1C that came back 10 minutes into our visit and it's 9.3%, and she tells me she'd been off her Bydureon for about 6 months. She just stopped it on her own before coming in to see us. So that's the setup there. Like I mentioned, medical history, type 2 diabetes, and then hypercholesterolemia. There was no hypertriglyceridemia, I don't think. Hypothyroidism, which in the past had been told was Hashimoto's, and then PTSD and mild intermittent asthma. Medications as listed there, the glipizide, 10 milligrams just once daily, rosuvastatin, 20 milligrams daily, levothyroxine, 125 micrograms, quetiapine or Seroquel at bedtime, Advair, 1 puff twice a day. She takes this regularly. Albuterol, which she said she had not used in over a year, so really well controlled. And then the citalopram or Celexa that she uses daily, and her mood was well controlled with the normal PHQ-9. Allergies to medications, sulfa medications, and I didn't get the specifics on what her reaction was with that one, or aspirin. And then metformin she tried early on in her diabetes course and had loose stools. She did say she only tried it once, so it probably was the short-acting form, but I don't know. It'd been over 10 years for her. Family medical history, diabetes and hypertension, I think mostly mom's side, maternal. Family history of heart disease in a mother, sister, and a brother. Not sure about the details on ages or anything. She is an RN with an associate's degree. I believe she works at a assisted living or long-term care facility. Single, no tobacco use, and really no alcohol use. The vital signs there, 5'2", 206 pounds, making her BMI about 37. I actually don't have her previous BMI, but she said she had lost like 20 pounds in the last year. Blood pressure 130/84 and heart rate 92. Couple labs from the visit. Glucose was elevated at 203. A1C, like I said, 9.3%. Creatinine was 0.62. And the lipid panel, triglycerides were quite elevated that day. But these all came back after the visit also. And then albumin and the LFTs were normal. TSH the year before had been abnormal, but she was taking her levothyroxine scheduled and regularly and had a normal TSH now. As far as her exam findings and her diabetes standards of care, everything was updated at this last visit. And dental, she does see them every 6 months. As far as diabetes self-management education, I don't know if she had it early on, but none now. And diet nutrition therapy, we didn't refer at that appointment. A couple barriers for her is insurance coverage. Up above it, it had said it was state insurance. She had done a prior authorization for that Bydureon that now would have to be completely redone because she had came off of it. And she was a bit overconfident coming into that appointment and having been doing so well for 10 years. Dietary wise, just got a quick dietary history from her for the last day before that. She does pretty well. Vegetable omelet for breakfast, does eat some grapes and orange slices and then yogurt in between. Salad for lunch, eats that at work. Doesn't have a lot of time to eat at work, just being a busy nurse. Then for dinner, she does have the turkey sandwich on whole grain bread and no bedtime meals.
Thank you. Does anyone have any clarifying questions for Grant?
Do you know if she's tracking steps or anything about her activity?
I don't. That's a good question. I know she's a busy nurse at an assisted living facility, so I think she's getting a lot of steps, and she wasn't wearing any wearable technology at our visit.
Is there any snoring or sleep apnea or risk for that?
Good question, but I didn't get that one either. But I'm taking notes now.
I know that there's a lot to get through in that 20 minutes or so, and you said you didn't have much of the cardiovascular family history, although it looks like it's at least numerically significant. I assume you didn't have any idea about kind of the relative ages and what kind of cardiovascular disease they were experiencing. If it's in first degree relatives like brothers and sisters, that means it's probably, especially if it's a woman, that's going to be early coronary artery disease. But any details about that? And then I guess looking for what the drivers are, looking at that cholesterol panel and knowing the patient's already on high potency mid-dose stat, still you have a total cholesterol that's high. Do we have any idea what her cholesterol was before she started the rosuvastatin?
I don't know what it was before she started it. I think she's been on it for many years, and I have labs back to 2018.
Great points, Kelly. So I actually phoned our friend, our psychiatrist, Dr. Paul, because of her PTSD history. From when we heard briefly, it sounds like she's fairly well controlled, but some of his questions were, was this acute, newer thing? Was this a childhood event? Do we know anything about the PTSD background?
It was over 10 years ago, but I don't know the exact circumstances.
Okay. Do we know the primary symptoms of the PTSD? He also said this was very important to elicit when we're thinking about medication adjunct management, like nightmares, sleep issues, or just mood, or all of the above, or are we not sure?
I believe it was mostly sleep issues, and that's where she takes the Seroquel at bedtime.
Got it. That's really important to elicit, and I actually learned something because when I was talking to him about this potential case is that 50% of it is actually tracking what is the main complaining system as part of the PTSD. So great information there. We always do our recap. So what we know is this is a 58-year-old female with a history of diabetes, hyperlipidemia, a BMI of 37 with an absolute weight of 207 pounds. She does have PTSD, although it appears well controlled. And she had previous well-controlled diabetes, but now the A1C is 9, and she presented to established care. We felt like Bydureon or exenatide was an effective treatment with her in the past. Currently, it looks like she's just taking glipizide extended release for her diabetes management. Of note, she does have a sulfur allergy. There is a little bit of a cross-reactivity, like 20 to 30%. So it'd be interesting to see. Obviously, she's on this medication, so no problems, but it is something just to keep in the back of our head. Also of note, and what we're going to focus on a little bit is the quetiapine, which is our Seroquel, and our citalopram as her medication choices for her PTSD now that we know her history a little bit more. Our individual characteristics, we do know that she is probably insulin resistant. We also believe that she has a normal kidney function. She is getting older, so she does have cardiovascular risk related to her age. She seems to have a mixed hyperlipidemic picture. I'm assuming maybe a little bit of genetic component given her elevations despite therapy on her statin. We will be addressing limitations based on her Medicaid formulary, as we'll discuss a little bit. With a lot of our psychiatric medication, some of them are not weight neutral and can cause significant weight gain. The first question we always ask ourselves is this person type 1 or type 2? And I think because she had this sudden change, we have to ask ourselves, could she become insulinopenic? Could she be latent autoimmune diabetes? I think the answer is no, just because she did de-escalate her medication. And we didn't hear, but I'm assuming maybe she had a little bit of weight regain as well. At this point, I think we can just from our clinical judgment, without any further laboratory evaluation, think about her having type 2 diabetes unless she doesn't respond to therapy as we predict her to. Our next question is, what is her A1C goal? I'm going to ask Barbara, what goal would you have for this 58-year-old woman for an A1C?
Less than 7.
Yep. And I would even say she'd be someone, if I don't have a risk for hypoglycemia because she's less than 60, I might aim for 6.5 if I can get her there without hypoglycemia. If we can use medications that don't enhance the risk for hypoglycemia or have little risk. Unfortunately, that glipizide is one of those that will increase her risk for hypoglycemia, especially as a nurse if she doesn't eat for periods of time. What about our non-pharmacological intervention? One thing I've seen with our cases is in general, it seems like our participants participants in the cases are eating a healthier lifestyle. One thing I really would want to know is just little things like her portion sizes, reading labels, because maybe her yogurt has an additional 15 grams of sugar in addition to the natural sugar she's putting with the fruit, or is it a plain yogurt that doesn't have any added sugar? I always tell people a salad from Sweet Green may have more calories than a cheeseburger. So it all depends on what's in that salad. Part of my evaluation of the salad is what type of dressing do you put on it? What do you add to it? Because a salad could basically be calorie free, or it could be a high caloric thing. And similarly with the sandwich, I always do just ask if they add mayonnaise or mustard versus do they add cheese to it, how many slices of meat, because we are trying to get a sense of their overall caloric intake. You have to be 500 calories deficit on average a day to lose half a pound to 2 pounds a week. Laura, I was going to stop there and just comment on it. I know the focus isn't about restriction and calorie use, but I do think sometimes just making people aware of it a little bit. I'm just curious what you think about that, because I think there's two different sides of that discussion.
Yeah, obesity as a disease. The first thing I always tell patients is not just eat less, exercise more, but definitely I agree we want to really just reduce that overall calorie intake, because as we lose weight, the metabolism slows, so the body adapts to take less calories. So we do need to really reduce that portion overall. Definitely several other factors for sure play a role.
Now, outside of non-pharmacological intervention, it is also making sure we support her overall mental health. These are just things I found from a quick web search. There is a meetup group for PTSD support that has activities for the local Seattle region. There is also a website that you can search based on your insurance criteria for a mental health provider. Then there was a specific group that does PTSD and anxiety evaluation, and it's a tiered program based on income. Those things might make it more accessible to people. And I'd love if other people would chat their resources. I know places like CMAR will have some mental health providers available. Share what you found to be best, especially since we're talking about PTSD in the setting of PTSD, so that I can share that with the group later on as well. One thing Dr. Paul said, that group therapy isn't necessarily the way to go for PTSD or support groups. He says if they're actively having symptoms, then it's best to do individualized therapy, including eye movement therapy, cognitive behavioral therapy, and cognitive processing therapy. So we do want that to be a component of their PTSD treatment plan. So now focusing on the weight, on the medication she's on. And I think the first thing we have to point out is that this was 10 years ago and she was doing well. So the question is, can we change something? That's something we'll have to do in partnership with our mental health provider. You can see the citalopram she's on, just like the SSRIs, tend to cause minimal weight gain, at most 5% or less. Quetiapine or Seroquel tends to cause a significant amount of weight gain. One thing Dr. Paul pointed out to me was it's actually the paroxetine and sertraline that are actually the FDA-approved medications for PTSD. And again, her symptoms seem well controlled, so I wouldn't necessarily change them to that. Additionally, we also know that the Paxil or paroxetine does cause the most weight gained out of the SSRI. So we probably want to avoid that one, but it is something to think about. I will put this in the community resources, but he gave me a nice document that was from a Harvard psychiatrist about what to think about and an algorithm for PTSD treatment of symptoms. So the first thing to address usually is the sleep issues or the nightmares. And medicine is actually the preferred initial treatment for nightmares, definitely using sleep aids if needed for the sleep disturbances. And then with the mood, it is looking at SSRIs as a first line treatment. And we already went over what is best, what is FDA indicated for those. What was in this algorithm was that unfortunately our quetiapine or Seroquel has a lot of negative side effects associated with it. So should not be used, hopefully long-term, as a sleep aid. I'm I'm Army physician. Unfortunately, I used a lot of this medication, and my soldiers coming back from Iraq and Afghanistan have seen the devastating metabolic effects that can occur from it. It was definitely maybe needed as an adjunct for their mental health, but it was not a great medication for other things. When we're talking about antidepressant medications, when you look at the literature out there, we know that bupropion is probably the most likely to cause weight loss. Remember, it is also part of an FDA-approved medication with naltrexone called Contrave. Again, we pointed out that fluoxetine may be one of those that does cause initial weight loss. And it's because the idea of it activates people like all the SSRI does. And so you're more motivated to do the activities you liked before. But then the overall long-term use of SSRIs may be that 5% weight gain. So it's something to think about and really reevaluate with your patients after that 6-month period. If they had an acute thing that they needed that support, if they don't need it, doing a de-escalation or trial off of it. But if they need it for the long term, just really reassuring them that a low dose, there's only mild weight gain that may be associated with it. Duloxetine or Cymbalta, again, the message is a little mixed. This really is that everyone is individualized versus the pathways for these things. The people were more likely to lose weight, at least initially, on duloxetine. The longer term, maybe again, weight neutral or a little bit of weight gain. We've already mentioned bupropion. The other thing I want to point out is from a side effect profile, from a sexual side effect profile, bupropion also has the lowest side effect profile. So it is something to think about in people who are complaining of that, because that is part of our whole body health and everything. This was a very disturbing thing in our patients that were on this medication for schizophrenia, but over 37% of them gained greater than 7% of their body weight. So that's a disappointing fact. And I think the only thing to think about is this person's been on it long term. So it seemed like most of the weight gain happens in the initial 3 months, and then it's more stable. So whether or not it's contributing to the weight gain or weight loss as much, and she's been on it a long term, is less understandable, but definitely perhaps coming off of it might help facilitate some weight loss. And what we seem to always see from all our psychiatric diseases is that they're all independently associated with weight gain outside of the medications, outside of traditional risk factors. And I think that's the hard part. And so we really have to pick the medications that can help them primarily with their symptoms first, but then hopefully that have a more positive metabolic profile. It is just partnering with the mental health provider, seeing where they are on their mental health journey to see if you can adjust or change, because obviously the mental health is the most important. How do we as physicians, if they do need a particular medication that has been associated with a poor metabolic profile, how do we perhaps help mitigate the risk? There's been over 1,000 people studied looking at topiramate and metformin as an add-on for a little bit of weight loss, with the average weight loss of just over 5 pounds with both of those. So definitely for her who had a brief trial of metformin in the past, this would be a great add-on medication for her diabetes management. If you did want to think about more appetite suppression, topiramate would also potentially be a possibility to try as well. Now, the data is really limited on our GLP-1 receptor agonists. They only have a total of 164 patients, and they looked at it with exenatide and liraglutide only in those that were on psychiatric medications, but the weight loss was much more substantial than with the topiramate and metformin. Again, these are the lower doses or the older medications. And so at higher doses of our newer weekly medications, we may get even more weight loss in this population, which just hasn't been studied. What was particularly powerful for me in this one particular study was that you only had to treat just under 4 people to actually see benefit from a weight standpoint. So that's a pretty powerful number needed to treat. This was the study that's sort of associated with it. All the cardiometabolic risk factors were a little bit lower, and it was favored if the patient was taking a GLP-1 receptor agonist. The next thing we want to talk about is basically in this patient, exenatide worked well for her. She was on the weekly exenatide. So as was mentioned by Barbara, there used to be an older version of exenatide where you had to reconstitute it, and I call it the shaky drug. I always would have to watch the YouTube video about it, where you would have to do something and then shake it and then do the next step. It was a very effective medication. I used exenatide under the trade name Bidurion a lot. Its limitation really was it had a bigger needle and you'd have more skin nodules associated with it. They would go away and were benign, but that was a limitation. it's now not become commercially available. And the exenatide, which is again in a pen form where there's no reconstitution needed, so it's a little easier for the patients, unfortunately is also an expensive medication. So it's not considered preferred by any of the Washington state Medicaids. Right now, we don't actually have a weekly preferred GLP-1 on the formulary for Washington state. The status is you have to try and fail 2 of their preferred GLP-1 medications. So what does that mean? That means you can use liraglutide, right? A daily dose, a small needle, easy to do, doesn't have to be timed to anything. But then if you don't get enough A1C lowering from that, or you have a GI side effect profile from that, you then have to go to exenatide twice a day dosing. And exenatide twice a day dosing has to be based prior to the first and the last meal out of the day, the 2 larger meals, and it has to be timed 30 to 45 minutes before the meal to really get that appetite suppression effect. You start it immediately before and you move it back to 15 and then 30 and then 45. But to really see effective appetite suppression effect and the weight loss effect, you want to time it so that it's given the right timing before the meal. Again, twice a day dosing of a medication based on meals. We do have to try and fail both of those 2 things before you can put in a prior authorization for a weekly GLP-1. So how do I do that? I start with liraglutide at 0.6, and then every 7 to 10 days, if there's no nausea or it's mitigated, I'll go up to 1.2 and then 1.8. After 2 to 3 months, I will check an A1C. If the A1C is not at goal, I then will move to the exenatide, and I'll go to 10 micrograms twice a day. And because they're already on liraglutide, they already are used to that medication. So it's okay to probably tell them to take it 30 minutes before, because they're already sort of in that class of medication. And I tell them, notify me in 2 weeks if you have any problems taking it and timing it to the meal, or if you don't think you're going to be successful or there's a barrier for you taking this medication. And once I've done those 2 trials, then I would go on to a weekly GLP-1 receptor agonist. Now that the 2 milligram dose of semaglutide is available, my preference, because of the slightly more weight loss potential, is to use semaglutide. Deglutide at the 4.5 milligram dose, if that was a preferred one over the semaglutide, also has good A1C efficacy. Both of them are about, at the high dose, are at 2 milligrams. So they may, with monotherapy, you may get her to her A1C goal. Maybe not quite, but hopefully if she also facilitates some added weight loss, even with monotherapy. Now, in her case, I would probably try to replace the glipizide with metformin. I would use the extended release and just start at 500 milligrams extended release. I'd probably do that once she's on a stable dose with the liraglutide, as we're taking a look at the effect of it. In her case, the question is, could we use bupropion or topiramate for further appetite suppression? In PTSD, there was just a 17-person study that showed that it was tolerated and helped with some of the depression symptoms. One of the risks of bupropion is that it can increase the risk for insomnia, so probably not the best choice for her. However, what's interesting, and I learned from my reading, is it actually improves REM sleep, even though it can create insomnia a little bit more. So maybe her quality of sleep would be better. Again, it's a very small, only 17-person open label study. So in her case, I probably would be more likely to add on topiramate and just keep her on the citalopram, since that seems to be working, and then maybe try to replace the Seroquel with a different sleep aid if able to. And then I'm going to stop here and ask, Laura, would you use phentermine in someone who has a history of PTSD, knowing that it's a 10-year past and she is currently well controlled?
Yeah, I think because the concern is phentermine is stimulating. It could affect your sleep as well, maybe more jittery. But if things are well controlled, I think I definitely have used phentermine, and it would be nice phentermine with topiramate actually together if we needed that for weight loss. But with her, if she's still having active symptoms, I might steer away from that as well, because sleep is so critical during weight loss as well. Chronic sleep deprivation could further aggravate her insulin resistance situation also. So we could, but for her, I probably wouldn't with her sleep stuff.
Yeah, I think you're completely right. So it'd be a stepwise process where we're going to try the GLP-1 for maximizing weight loss. We're going to try to replace the Seroquel to see if she can get effective sleep with it. And then if we get a plateau at 6 months and she's stable from a sleep standpoint, maybe that would be someone we would start a low dose on it. Great point there. The other thing I just want to point out, even though there hasn't been any interventions that show how to improve this, but unfortunately with post-traumatic stress disease, it's actually an independent risk factor for cardiovascular risk outside of hypertension, diabetes, family history, etc. This was a very sad statistic that I found. With patients with PTSD had double the risk of death from heart disease during a 15-year follow-up, and each 5-point increase in PTSD symptom score corresponded with a 20% increased risk of heart disease mortality. And this is in her history of significant first-degree relatives with heart disease. It's outside the scope of this discussion to talk about the mechanism. It could be a whole lecture, but inflammation in general seems to be higher in post-PTSD. Interestingly, they tend to have lower baseline cortisol levels, but these exaggerated cortisol responses, which probably isn't helping them with weight loss. And a lot of it is environmental or just behavioral choices that you tend to see in patients who are struggling with mental health diseases in general. All those things probably contribute to it. When you do her risk calculator, because of her age and diabetes, she does meet the threshold at the 7.5% to be on a high intensity statin. We already talked about that. And Kelly, can you comment for us in people who have maximized or gone up to, let's say, atorvastatin 40 to 80 or rosuvastatin 40, when you would use ezetimibe?
So it's an interesting profile for this patient. In that when you are looking at the ratios of cholesterol and HDL and LDL, and unfortunately, it looks like it's a little conflicted. The triglycerides are quite high. I assume this was non-fasting. But even so, as you're looking at the LDL to HDL ratio, this looks very diabetes, insulinopenic, insulin desensitive, only because the HDL is low. Now, in the setting of rosuvastatin, actually, you generally get a bump in your HDL versus something like atorvastatin. And so in patients that have very high triglycerides, I will generally use atorvastatin because it's really going to lower your triglycerides more, and you get what we call hypolipidemia. Everything goes down, including HDL, unfortunately. Whether or not that's a big contributor, we don't know. But for somebody like this, my bump from 20 to 40 of rosuvastatin really isn't going to give that much of a huge gain. I'll probably get 6 to 10% additional lipid lowering, but not much more. So oftentimes I'm adding on medications, and generally I'm heading towards ezetimibe. Patient based on the risk profile would not be a candidate for PCSK9, even though that would work very well. Niacin, obviously, we haven't been using for many years, even though that would make the numbers better. We did aim high and showed that, and HPS2 Thrive is another study that showed that niacin just didn't really help all that much in patients with secondary prevention. Probably not going to help here. And we could use some bile acid sequestrants, as you see there, but they do have a lot more side effects. Sure, you could bump to the rosuvastatin, see what happens, get a fasting cholesterol, just so you know what's going to happen with the LDL. And the triglycerides. Make your determination if you're going to try to be more aggressive with the triglycerides or not. And then if not, just add on ezetimibe at that point.
I think everyone's probably in agreement. We want to optimize the LDL. And so with her triglycerides, I had the same thought. Now, remember, in a younger person, birth control maybe, or estrogen therapy, HRT may be a reason to have higher triglycerides. I believe the quetiapine as well, or Seroquel, also has some triglycerides raising effects. So all those things could be factoring in. What I wanted to just share was that weight loss is a great goal because you will get some significant lowering of triglycerides from that. And if we can get her aerobic activity up, you also will see improvement in that. Can you comment a little bit about therapy for triglycerides and heart disease, Kelly?
Sure. The best data that we have is what you have here, Vasepta or icosapent ethyl. And then again, that is only in a secondary prevention population, but very effective. This is in contradistinction to what we see with the omega-3s, which is there's no benefit whatsoever other than pancreatitis in very high triglycerides. Just try to get it through everybody's head that omega-3s don't work as you get from Costco. They just don't. We have over 100,000 patients in randomized trials. They don't work. Get rid of them unless people want it for their fingernails or their hair. But if we could do icosapent ethyl, it'd be a nice thing. The problem is patient's not sick enough, hasn't had events. So it's a very expensive medication, so you won't get it covered. Other than that, trying to do what you can as far as treating the diabetes, that actually obviously may help reverse some of what we're seeing as far as the triglycerides, as well as the LDL-HDL ratio, the A to B ratios. So that can be helpful. The patient wasn't drinking, so alcohol doesn't really make all that much difference. But I think better diabetes control overall, making sure the triglycerides really are that high, is going to be very helpful to help us figure out what we need to do. And then go from there. If we really want to add on something, there is some data that doing some of the cholesterol binders can be helpful, but I'd be targeting more the LDL, to be honest with you.
Great point. And again, yes, usually you target triglycerides if they're less than 500, only in those who've already had a primary cardiac event. Now, Nyan, our nephrologist, has been a little neglected because she does have normal kidney function. And Grant, I might have missed this. Did she have a microalbumin check recently?
It was normal, I believe.
Okay. And someone like this who, again, does not have a primary cardiac event, but has a really strong family history and has this PTSD history that might also increase the cardiovascular risk. Talk to us a little bit more about the newer guidelines for diabetes in those with renal disease and high cardiovascular risk and blood pressure goals.
In general, I'm a big proponent of targeting the 120 systolic instead of higher goals. And that obviously comes from SPRINT, which showed a significant decrease in cardiovascular events and mortality. The caveat being that, of course, SPRINT excluded patients with diabetes. But if you look at the ACCORD trial, which is traditionally looked at as a negative trial, if you exclude those patients that were randomized to the tight glycemic control, which is not standard of care, those patients, even without, even with the standard glycemic control, they did have benefit, particularly in stroke risk. That's going to be your biggest association with blood pressure reduction, is your decrease in stroke and mitigating other cardiovascular events. Now, the caveat in this case is that we have one blood pressure. It's a clinic blood pressure. So what I tell everybody, it has to be done correctly and measured correctly. So how that works is patient has to have an empty bladder, which can increase blood pressure by up to 20 points. They have to have feet firmly on the floor, back supported, arm supported, no talking for 5 minutes, at least 30 minutes post any exercise or caffeine, and it has to be checked that way. That's why we rely strongly on home blood pressures and then using ambulatory blood pressure monitoring as needed. The one thing to point out is that this blood pressure lowering is not going to protect against future kidney outcomes in the absence of albuminuria. So we're just talking about cardiovascular outcomes, and again, it has to be measured appropriately.
I think that's a great point, Nyan. We have not been able to show benefit with people who have normal blood pressure and no microalbuminuria for using an ACE or ARB. Oftentimes, it seems like our patients living with diabetes are put on that irrespective of what their blood pressure is, irrespective of their microalbuminuria. And all the rest of your points are very important as well. Just making sure we have an appropriate blood pressure check is the first standpoint. My final part is the good news is weight loss is key and will help all of these things. And so what we can extrapolate is potentially she does want to be on minimal medications, given the fact she did discontinue her exenatide in the past, and really focusing on weight loss as a goal plus her glycemic management, then considering these things as an add-on as we're assessing her cardiovascular risk as you build a partnership with her, is what my thoughts were on it.
Nicole, actually, I'd like to just add, this patient, I think for sure should be considered for metabolic surgery. Her BMI is over 35. She has type 2 diabetes, and potentially with surgery, that's going to give her the greatest amount of weight loss, a more permanent changes, increased GLP, decreased ghrelin, which makes us hungry. So I definitely think if her mental health is stable, she's not smoking, there's no disordered eating. With her insurance, you'd have to submit a prior auth and usually do the 6-month medically supervised program. But yeah, I think she'd be a great person to think about surgery.
Yeah. And I think what Laura brings up is that we should start this discussion about metabolic surgery early. It doesn't mean that they need to have it, but we start the process for them so we can continue to partner with them as we're working on medical weight loss as well at the same time. So I will say this ends session 5 of the Cardiometabolic Echo.